My distinct pleasure today to introduce Dr. Nneka Sederstrom. She earned her Bachelor's of Arts degree from George Washington University, her master's in philosophy and public policy at Howard University, where she also earned her doctorate degree in medical sociology and race, class, and gender inequalities. She served as the director of the clinical ethics department at Children's Minnesota for almost 5 years, and recently has joined the executive leadership team at Hennepin Healthcare System as the new Chief Health Equity Officer. I love that title. I can't wait till we have a Chief Health Equity Officer, where she leads efforts in addressing health disparities, equity, and anti-racism in the institution and the community. Dr. Sederstrom is a member of several professional organizations and has leadership positions in the Society of Critical Care Medicine and in chest medicine. So we are delighted to bring her today to talk about racism in medicine, where we were, where we are, and where we will be, or where we're going. We're really excited about that last part, giving us some direction on where we hope to go. So I'll turn it over to you now. Thank you, Dr. Sederstrom.
Okay. So before we begin this conversation, I want to take a moment and just kind of set the tone and expectations. I've spent my career in clinical ethics and in medicine and health equity, trying to ensure that I hold space for patients and for families, for providers and in the employers, students and trainees, and for other ethicists as well. And trying to hold this space is a deliberate and necessary act. We need to value it, and we need to recognize the importance of holding space. So for this talk, what I want to make sure is that you take the time to hold space for the truths that you will hear in this presentation. Some of them you've known, some of them you've never known. We're hoping that this holding space will lead to allowing other voices that maybe have never been heard to now speak up. We don't want this space to be dominated by voices that always tend to speak, which require silencing others, but to really take a lot of time and a lot of introspection in figuring out why one feels either comfortable or uncomfortable with this information, and use that discomfort to examine where those emotions came from and what are the experiences that may be bringing up the emotions. So I want to just set the tone by saying this is a space holding situation, and it will be potentially emotional for some. It may be hard for others. And I just want you to sit in it and hear it, and then we can talk about it at the end. So with that, we'll begin our journey. There is a famous quote that says the best place to begin is at the beginning. So I always believe that that's where we should start. We need to know where we come from before we know exactly where we are and have the hope of understanding where to go in the future. So in the podcast 1619, the author states, starts off with this very powerful statement. She says that no one knows when it was that the realization set in that there were no more opportunities to hug a loved one, to hug a grandparent, dance with a cousin at a celebration, or kiss a child. Did it take 1 week, 2, or 3 on the open waters of the Atlantic Ocean to irrevocably break the ties of a people, their culture, their safety, and the security of home? Some decided that this break was just not acceptable and chose to jump overboard and take one final swim with their ancestors. Others chose to die from hunger strikes, deciding that death was a more favorable outcome than waiting what their chances were at the end of these waters. This view is from the Atlantic Ocean, standing on the shores of a Caribbean island that many of you may have enjoyed. This is also the view that millions of captured Africans saw when they arrived at their final destination. So we know the story. Africans, some stolen, some captured, some sold, and some freely given based off of lies that were told of better opportunity, were encapsulated in the hulls of ships that were termed slave ships and brought to the new colonies of the Americas to be sold into chattel slavery. The first of these ships was the White Lion. 20 or 30 Africans enslaved on this pirate ship called the White Lion landed on the shores of Point Comfort and wanting to be used to be traded for goods and services. The pirates only had the people and chose to trade the people into slavery to the colonists in exchange for the goods and services that they needed aboard their ship. So in 1619, this was the birth of slavery in the colonies that eventually became the Americas. So when you hear the date 1619, it's embodying this act of this first trade of Black Africans into slavery into the American colonies. It is estimated that between 1500 and 1866, Europeans transported nearly 12.5 million enslaved Africans, which included going to Central and South America, where the vast majority of these captured slaves went to South America. About 1.8 million of these people died during the transatlantic voyage known as the Middle Passage. And what we know of the difference between North America and South American slavery is that only about 5% of the total captured Africans made it to North America, where the future United States is, during the slave trade. The vast majority of these people by 1860 were born over many, many generations into a life of slavery. So we have to really kind of understand the dynamics of how Black people enslaved in America came to be. It wasn't because of the majority of the slave trafficking through the slave trade, but it was due to the birth and of multiple generations of Black people on American soil and born into a system that has established them as slaves. And so these people were made Black by people who decided that they were white. And then this new place, Black meant slave. Those who were strong enough to make it through the Middle Passage now had to forge a new sense of personhood, one that included an understanding that their bodies, their minds, their spirits, their religion, none of that belonged to them anymore. They belonged to others who decided that something about their skin color, about the melanin in their skin, gave them the right to be claimed ownership over them. So a new link had to be forged for the sake of survival, and that link was with each other. And it was welded together by the lived trauma of enslavement. They were now each other's people, even though some of them didn't speak the same languages, didn't come from the same cultural traditions. They were now each other's sense of identity. They were now also each other's only hope to maintain any sense of humanity, the need for connection, the need for community, and of course, the need for family. So for hundreds of years, Black people lived under the continually controlling power of dehumanizing. They were beaten, traded like animals, tortured and enslaved. Their families were broken and intentionally torn apart. Their bodies were mutilated. Their humanity was not only denied to them, but also was stolen. There was no reprieve, no safe haven, no place to go to get away from the trauma. Just a continuous understanding that if you were born Black in America, you were not considered a human. Your life was a continuous traumatic experience. And it's completely impossible to understand the full impact of those 200 plus years of chattel slavery that were the foundation of this country. We do know some truths though. We know that life expectancy was shorter due to the violent living conditions, the unsafe living conditions, the violence of being in slavery in of itself. We know that half of the babies that were born to slave women died. We also know that there was no medical support for slaves. And so if you got sick or you got an infection, you died from it. And the list is much longer, but this at least helps to paint the picture of how hard it is to measure the full impact of the violence of slavery on Black people. And what we also know is that trauma imprints. If you've not read this book by Resmaa Menakem, I highly, highly recommend it. It's called My Grandmother's Hands. And in it, Resmaa talks about living under the traumatic conditions of white body supremacy. And he specifically states it as white body supremacy versus white supremacy, because he fully discusses, which I believe is also true, is this reality that the trauma of the conditions that have created white supremacy based off of the white bodies being supreme has created Black body trauma and white body trauma. So we are all affected by white body supremacy. No one can actually get away from it. And what we know about trauma is that it has imprinting elements on our DNA. Excuse me. So let's just take a second to note some of the facts that are important about this continuous traumatic effects, and it helps with our conversation. As we discussed, the America was built on this foundation of slavery and white supremacy. And so we know that violence and trauma affects experiences of people generations to come. Black people in America and white people who witness traumas to Black people in America all are affected by this trauma. That violence and trauma just doesn't go away because slavery has ended. There are multiple additional things that cause trauma to be maintained in the body. As we see here, childhood trauma affects the DNA. Violence causes biological effects on the body, specifically impacting the brain, neuroendocrine systems, the immune response, resulting in depression, anxiety, PTS, suicidality, cardiovascular disease, and premature mortality. So these are the facts. Children exposed to violence have a long-lasting impact on their DNA, and the violence that causes these biological effects are seen on the body till this day. Today, we are seeing the Black people who are the children of those who were enslaved and were part of this continuous exposure to violence and racial trauma. And we're also seeing today the white people who are the children of those who were the oppressors and the bystanders during those racial violent and trauma experiences during the 400 years of slavery in America. And this is where I believe this work is that it's not a separation of the two, but it's an ownership that this affects both Black people and white people in this country. And how do we address the trauma of those 400 years in a way that is meaningful, that moves us forward? So let's look at how all of this relates to medicine. First, we have to start off with a clear definition of trust. The basis of any good medical relationship is the physician-patient relationship, and that has to be founded on trust. We know as clinical ethicists, as other team members, as respiratory therapists, as nurses, as nurse practitioners, any relationship between the clinician and the patient or the family and the team has to be built on some sort of trust. And this definition of trust is really important to keep in the forefront of our mind, because as we think about the relationship of Black people to the medical establishment in America and our continuous need to start acting in a way that's trust building, I don't think that we take enough time to truly understand what the definition of trust is. A firm belief in the reliability, truth, ability, or strength of someone or something. And I want us to just be mindful of those elements: reliability, truth, and ability or strength in someone or something. So once Black people were notified of their freedom of being enslaved on June 19th, they were completely just cut loose without anything to help with the transition. There were no homes that were made available, no property able for them to purchase, no food, no safe places to gather, no safe conditions in period. So this led to hundreds and thousands of people gathering in abandoned buildings throughout the South. Those living in close quarters had very little to no hygiene opportunities. And as you can imagine, that led to public health crisis. There was actually a really large smallpox outbreak that led to multiple mortality rates in the Black community of the newly freed persons. And that began to trickle into white communities. And as a result, the Freedmen's Bureau was created. And so this Freedmen's Bureau division was supposed to address the issue of the newly freed slaves in a way to keep them from filtering into the white population with additional diseases. But this bureau that was set up by the government as sort of the first medical program for the underserved was set up to fail. Only had about 100 doctors to cover tens of thousands of freed people. They didn't have enough beds, sheets, linens, medicines, or quarantine opportunities, any place for people to actually come together and get well. So there were folks that tried to fight this, but because of the lack of the resources and people actually in government really being willing to want to do anything about it, it was destined to become a problem. And it became such a significant conversation in our government discussions that there were people who created this idea that the newly freed slaves slavery in of itself was a public health program. That newly freed slaves, for whatever reason, there was a biological difference in Black bodies that led to their inability to fight off disease as a result of being free. So they started having conversations about freedom being a terminal condition, and that there is such a difference between Black people and white people, and Black people just physically should not be out of slavery, that slavery was actually better for their health. And we'll just fast forward a little bit to recent history within the last 3 to 5 years. Many have heard this argument come up again, that slavery wasn't as bad as we thought it was, and that there were many people who were, quote, happy in slavery, and that there were many owners who took care of their slaves better than when they were free. And so what this led to is the beginning of a eugenics movement that attempted to push this narrative of a biological difference and a justification for the separation of the bodies, and a continued discrimination. And this reached to the highest level of our government. President Andrew Johnson opposed the improvement of hospitals for the care of Black patients. Discussions on increasing investments were seen as wasteful and foolish, and even made it to the House of Representatives to be used as an argument for defunding hospitals. And if you can see in this picture of a front of a newspaper, it clearly states that to keep the Negro in their place, the president is willing to deny the funding that they think is wasteful in order to address it. But Congress was trying to figure out a way to actually give money to these hospitals that were trying to take care of Black people. And so if you wanted to be on the side of right, which was the side of white, then you would want to maintain the president's agenda and protest Congress trying to put money into the funding of the Freedmen's Bureau and further money towards supporting Black lives. So this was the beginning of government institutions claiming to Black people specifically that you have to figure out a way to take care of yourself, because it was really clear to Black America that the government and the medical institutions and establishments were not there to take care of Black people. And so that led to what was seen across the country as this mass segregation within hospitals, being denied admission into white hospitals, being not allowed to be taken care of in beds and things that were set up especially for only white people. So they were moved to the basement. White nurses in particular were not allowed to care for Black patients, especially white women were not allowed to be near Black men. And the majority of nurses in those days were all women and all white. We were only allowed to be treated at Black facilities, but there were so few of them. My alma mater, Howard University, was established, and the hospital was established as the only hospital that has outlasted from the Freedmen's Bureau to take care of Black people. And white physicians rarely engaged in trying to address the needs of Black patients, even if they were allowed in their hospital. So if we rewind a little bit and go back to this concept of trust, again, right, the basis for the physician-patient relationship and the relationship with medicine and clinicians in general with patients and families. Those things that were required were being reliable, being truthful, having the ability and trusting and strength. And if you look at what the story of how Black people in the early stages of being freed in relationship with the hospital system and healthcare system, there was no ability for any of these elements to come true. The hospitals for Black people were under-resourced and neglected. Government officials, including the president, were making arguments that enslavement was a better condition than freedom. There was not enough physicians or resources to try and care for them in any capacity. And there were people strong enough to fight for their rights, but they were very few and they had no political acumen. So they had to create ways to fight within the community. Rebecca Lee Crumford, Dr. Crumford, was the first Black woman to graduate from the New England Female Medical School. And she started a movement on educating other Black women in particular to take care of themselves and their families in this book that she wrote called A Book on Medical Discourse in 2 parts. This was truly the beginning of Black people believing that the only way to get good healthcare is to do it themselves and trust their own and to be cared for by only Black bodies. Dr. Crumford was one of the strongest advocates for health and well-being in the Black community. And she was phenomenal in changing how Black people created better ways of taking care of themselves within their own. And now we can fast forward a little to today, and we've seen the effects of this now. We've seen data that shows that clinician racial concordance has the highest impact on patient outcomes, decreasing the disparity over anything else. This is the beginning of where that came from. It's decades later of having the opportunity for Black people to feel safe and feel that immediate trust component with other Black clinicians. In the coming decades, that led to the opening of medical schools and hospitals and created opportunity for Black people to finally get healthcare and become clinicians. I just continue to perpetuate this feeling of the only safe place you can be is with other Black people taking care of you. And it wasn't because there were actively white people trying to take care of Black people. As a matter of fact, there was a lot of lobbying from some of the most powerful medical societies and organizations during that time, like the American Medical Association, which at the time was an all-white entity for physicians. They spent lots of money and time advocating to maintain these separate but not equal segregation laws so that they wouldn't allow Black people into healthcare systems and hospital systems. They also destroyed the first attempt of a universal healthcare that was proposed by President Truman. And they refused to acknowledge or allow Black physicians who were around at this time to be part of their membership, even after there was a big push to start having Black doctors move into mainstream to try and care for Black people. They still refused. They've since apologized for this foundational history, but during the time, it was a very powerful effect on the medical society. So what finally gained traction was the creation of Medicare. And it was widely supported by Black physicians and white allies who believed that if you took it out of the race conversation and focused it on the age conversation, that was a better way to allow for desegregation. Because when hospitals now were able to get money for caring for the elderly, regardless of race, that meant a significant amount of income coming to the hospital. So that created this financial carrot and stick element to have hospitals comply with the new desegregation laws that were a result of the Civil Rights Act of 1964. So as you can see, that this was a year later. Many hospitals at the time had not agreed to desegregate. But once Medicare came out and the government was now paying for you to take care of people based off of age, it took only 4 months for 3,000 hospitals to finally desegregate. Now, this desegregation was because of money. So I want us to be really clear. It wasn't because hospitals or the medical system or physicians or healthcare administrators decided that caring for Black people was the right thing to do. This was only because they now got paid for it. So that is the way our hospitals built themselves, and that has moved into today. There's no way to see in history where hospital systems were created specifically to try and right the wrongs of slavery, that they just kept going now as a result of the way the healthcare system was being built around the concept of Medicaid and Medicare. There's a lot of examples throughout our history about the atrocities of Black people and with the medical system. And this is an amazing book that I also encourage you to read by Dr. Harriet Washington, who is a bioethicist as well. And it's called Medical Apartheid. And I will also throw out another great read by Heather McGhee, and her book is entitled The Sum of Us, which is an incredible look from a healthcare and an economics perspective of how racism costs all of us. Because again, like I said earlier, that this is not just something that affects Black or brown people, this directly impacts all of us. And her book does an amazing job of showing how this history impacted us till today and how much it cost us. So where are we now? You may have heard of all the studies that have come out. This was one that came out in JAMA a few years ago, and the statement that came out that was highlighted when this came out, I think is really powerful. It says that while the country has made some notable health improvements in recent years, deep and widespread health disparities still persist, and in some instances have grown. And there are lots of places to find where that data is shown and how this growth and these gaps in health disparities are. I will not go through all the data because it is very easy to find. You can look at reports within your own region if your hospital or healthcare system doesn't have their own version of their clinical outcomes and their disparities. Your region does, your county does. But I encourage you to actually go find the data because it's really important to understand where you actively sit before we can figure out how to go forward and address these equity gaps. But in that report that I just highlighted, I just want to pull out some of the notable disparities. And you can see that it is driven specifically by systemic inequalities in social, economic, and environmental conditions. What is implied here, but not actively stated, is that all these conditions have racial implications and are exacerbated due to racism. And that's not something that is a guess, that's something that we know is a truth. And if we focus on the top illnesses in this country for morbidity and mortality across the board, African Americans and Black Americans are more likely to die at an early stage from all causes. This was a situation prior to the pandemic. And as we know, we saw that the pandemic caused it to be even more exacerbated. We have way more Black people and brown people dying as a result of COVID than any other race, to the point where now there have been 2 years of life expectancy dropped off of the Black person's life as a result of COVID and the devastation that it's wrought within the Black community. And these are burdens of Blackness that Black people carry, and these burdens are due to anti-Black racism that is still very prevalent in America. And there is no story that does this more justice than the tragic death of Dr. Susan Moore, who, while it was happening and while her care was being impacted due to her being Black, she talked about it, she tweeted about it, she put it on social media, she begged for help and support in her own institution. And it had nothing to do with her education, nothing to do with her socioeconomic status. She was a physician. It had everything to do with the fact that she was Black. Now, many want to argue that because the institution came back and said it wasn't due to her Blackness, that it was just a sad situation. What I want to say, and I want people to hear, is that the reality is when Black and brown people say that they're being mistreated because of their race, your only thing to do is to believe them. It is impossible for white people to understand what it feels like to have your life be challenged due to your race. And so therefore it is impossible for that judgment to come through. It doesn't matter what's written down in the medical record. It doesn't matter what someone says. There are elements of feelings and clear understandings that are conveyed that you only get when you are from that cultural background. So when someone says, "This is because I'm Black," please just believe it. So our bottom line of where we are right now is that we're living in a culture of inequity. The truth of racism being the foundation of clinical practice in the United States has yet to be reconciled. We haven't said to ourselves as a field that our field of medicine was built on racist premises until we haven't reconciled the past, and therefore aren't going to be able to do anything with our future until we do that now in the present. We still train clinicians on white body normativity and don't look at Black and brown bodies as normalized. They're seen still as others. We need to address the disparities immensely. And we know that the expansive gaps in outcomes come from various elements, like not having enough clinicians of color to help with building that trust that's needed. So we need to work on figuring out ways to ameliorate them and stop just finding more and more data to highlight that they exist. I'm completely over the data in that element because it feels a little like data fatigue, and we're just continuing to say the same things over and over again. We know racism exists. We know that it causes health disparities, and we know that it has direct impact on health outcomes. So it's now time to just ameliorate and stop studying saying that there is it. It's like people are looking for that one element where the racism doesn't impact health, and they're just never going to find it. So again, the bias in our care delivery must be highlighted and exposed and not tolerated. So where do we go from here to create this better future? You've heard phrases like, we've lived in the twin pandemics of COVID-19 and COVID-16-19. And these kind of elements are, I feel, how we start to have these conversations, because it brings together the past and the present in a way that helps us figure out what to do in the future. And for me, the future starts with empathy. And the definition of empathy is really important, and I love it, and I think it's something that people should always hold on to. Empathy is the action of understanding, being aware of, being sensitive to, and vicariously experiencing feelings, thoughts, and experience of another of either the past or the present, without having the feelings, thoughts, and experience fully communicated in an objectively explicit manner. So basically, the idea of taking just a little bit to see the world from someone else's perspective and take a step in their shoes and just try for a minute to remove yourself and your life experiences in your lens, put that on the shelf, and try and understand where the other person is coming from and where their experiences are and how they're feeling the world. And I fully believe that empathy is our path forward. And that's because research has just kind of shown that it is. Empathy has resulted in increased patients' reporting of their symptoms and concerns. It builds trust. I know that, and people often say to me this all the time, they're like, Nneka, when you say that racial concordance between clinician and patients is the number one thing to decrease disparities in outcomes, are you saying that white doctors can't take care of Black patients? And that's not what I'm saying. What I'm saying is that the quickest way to decrease disparities is to have racial concordance, but that's not the only way. And it's not the only thing that's going to be feasible and realistic to do. There will probably never be a situation where we have enough Black and brown doctors to take care of Black and brown patients. And that shouldn't be the world that we try to create. What we have to do is, while we're building up those clinicians of color to be able to help augment the clinicians that are already there and have the biggest impact, because every day that we don't have impact are days that people die. We also have to train our white clinicians on how to build trust and create those relationships with Black and brown patients in a way that it elicits the same response. And that trust building starts with empathy. If we begin to teach empathy and how to create an empathetic relationship between a white provider and a patient, then that will show that the patients will do things like increase their symptoms and reporting concerns. They will participate better in their care, and they will be more compliant and have better satisfaction. But what we have done a poor job of is building that relationship. There's this assumption that just by virtue of being called doctor or provider or clinician or whatever title you want to do, that the people who come to see you ought to have some sense of respect and trust just because they're in a vulnerable position, and your job is to try and help fix that. So there's a little bit of this paternalistic view of like, you come to me for help, and so my job is to fix you, so therefore you should just listen to what I say and do what I want you to do. But the reality is that you're missing the element of building a trusting relationship, because people will still come, they'll still go to hospitals. People will always go to hospitals and institutions when they're sick and when they are in need of help because they're in vulnerable positions and they know that's the only place to get help. But if we don't figure out how to start practicing with empathy in those spaces, then we're never going to be able to create environments where all patients can have the best outcomes and be cared for by all providers. And that starts with owning who we are. We have to figure out who we are in order to figure out how to practice empathy better. And part of understanding who we are is by owning the reality that our healthcare system and our society as a whole is based in a culture of white supremacy. And this is one of my favorite just graphs or designs or images, is what you want to call it, of this iceberg effect, because there's so much work that has to be undone. But the first part of it is owning the fact that these acts of bigotry and these explicit issues, the very visible racism, like saying mean things or racist things or microaggressions or being overtly insensitive, that's not where the work lies. That's where people assume the work lies, is that if you just can go about and have a day where you don't hear a microaggression or you don't hear a racist joke or some of whatever those little sort of surface things are, that then we're making success. But the reality is it's that this significant amount of work that's under the surface around access, healthcare opportunities, disparities, underrepresentation in politics, infant mortality, all these massive conditions underneath that maintain these structures of racism. That's where the work really lies. We will always have times where those surface things can be addressed in the moment and make some sort of impact at that second. But if we truly want to get to a point where we're making a difference on how racism impacts our patients and our families and the people around us, we really have to get at this huge amount of work that's underneath it. And in medicine, that looks like is being really intentional on decolonizing medicine. We have to own that. We must realize that decolonizing medicine means diversifying who are the professors, who we read and learn from in the academy, where we make spaces for people to use their voices as patients, as providers, how our professional societies are put together, who speaks at these societies and these meetings, who do we uplift as examples of who we want to be. No longer can we just say as a profession that we are here to heal and to help and to cure if we don't take the time to really understand a very obvious truth that we've denied, which is that our profession is based on colonialism, it's based on white supremacy and racism, and we've done nothing to actively force ourselves to go against it. We also must destroy the structures that I say like under on the big part of the iceberg, the structures that are what continue to perpetuate racism in our society. And if we're not actively working against these structures, then we're continuing to accept them. It's not enough to just say that you're not racist or don't have racist tendencies or you believe in everyone should have the right equality and all those words. It's not enough to say it. You have to actively fight against racism and do things differently in order to dismantle these structures. If you're not actively doing things, then you're continuing and perpetuating in its acceptance by continuation. And then finally, we must denounce white supremacy. That's a complete sentence in of itself. So a few things to remember as we wrap up so that we can have some time for conversation and discussion. We bring ourselves and our biases into the room with us. I think people often forget that when they walk in, there is a presence that walks in with them. The first thing people notice about you, if you take a second and think about when you walk in, what is the first thing that you notice about the person in front of you, and what do you assume is the first thing they notice about you? For me, the first thing is Black, female, tall, dreads. Inevitable, that order. That is the first thing. I can see it on people's faces. And as soon as I walk in, there's a notice of it. And then that could be followed with shock, which happens a lot when it's a white family that I'm talking to, is shock, or relief, which happens when I walk into a room of a person of color. So we need to own that you walk in and then your biases walk in with you. So if you haven't taken the time to figure out who you are and what you present when you walk into the room and what biases you may have, that causes already a disservice between you and the person that you're supposed to care for. So think about that. It's also okay to have that biased or racist or sexist or homophobic or gender disparaged thought. It's just not okay for that to be your last thought. This is a learning journey and everybody is on it because we are trying to create a world that doesn't exist. We're trying to build an America in an America that's never been before. So it's okay to have those thoughts. It's just not okay for it to be your last thought. You must own the thought and figure out a way to actively go against it and do something different. That's the only way that we can build for the future. It is your duty to understand the additional factors that affect the patients and their outcomes. It's not sufficient to just do a review of systems. You must take a second and look at the environmental structures, the systemic structures, the social determinants of health, all of the elements that racism impacts. You have to look at those additional elements to better understand what will affect your patient and their outcomes and try to mitigate those. It's not simple enough to just say patient's not complying with their medication. Why? What is causing that? And how can you help mitigate that? Because that's where the real work is in building the trust and actually improving outcomes. And staying with the surface stuff is never going to get us where we need to be. We individually all have power in our own spheres of influence. If you look at the people who you influence or who influence you in your life, who are in your concentric circles, think about who makes up your family. Is there diversity in your friends? Is the only place that you see any sort of diversity, whether it's racial, religious, gender, sexual diversity at work? Do you have people that you come home to that fit those elements? Do your children have people within their lives that fit those different diversities? And if they don't, why? If you're very monocultural in who you are around, you need to ask yourself why. What are you not seeing or doing that is allowing you to stay in a little bit of a tunnel vision? As we know the importance of how diversification improves our everyday lives and our everyday experiences. So we each within ourselves have the power to influence those changes and those outcomes and create opportunities to diversify our spaces and help others diversify their spaces to just create a more richer environment. And then finally, you have to do the work to know your own blinders. You have to own them, and then you have to improve them. It isn't efficient to say to a person of color or to a woman or to a trans person, tell me what you need me to do, or tell me what I should know. That's not their job. You need to own that you don't understand that space. When you went to school to learn how to be the professional that you are, you read the books you needed to do, you studied the material, you learned the craft, you practice. You did all these things because it was important for you to gain the skill. This is just as important. You need to read the books, learn the material, talk to people, practice, figure out how to become better at being anti-racist, better at being homophobic, better at being not homophobic and dealing with LGBTQ plus gender issues, better at looking at gender equality issues. That is your job, is to figure out where you are failing and what you need to do to improve yourself. It's not anyone else's job to put it together for you. Just like you figured out how to be who you are as a clinician or a provider, as a teacher, as an educator, as a trainer, you need to figure out how you need to be in order to be better in this space. And I always like to end my talks with this powerful quote by Maya Angelou, and it's what I try to live by every day. To do the best you can until you know better. Then when you know better, just do better. It really is that simple. And we all now know this a little bit better. So I'm going to expect from you all to just do better. Thank you. I think we have about 15 minutes for Q&A.
I just wanted to say thank you so much for that amazing talk, and we'll turn it over.
I'm sorry, it's really low. I can't hear you all of a sudden. Me. Oh, there it is. It probably was me. Sorry.
Okay.
I hear you a little better now.
Okay, great. I just wanted to thank you for that amazing talk. And I think Stephanie and Stacy are going to help us moderate some questions or comments. But thank you. That was so amazing. And it took us through so much. I feel like I'm going to have to watch it several times to get everything, but that's okay. I don't mind at all. So we will now open it to questions or comments from the group.
And we are allowing people to unmute themselves. So let me put the gallery back so everyone can see each other, and let's make this a great community of practice. And feel free to unmute yourself, raise your hand, and I'll start, because the only question, which is not a question, but a suggestion, Dr. Sederstrom, is that may we have the slides to share with this recording, because everyone would like to, as Dr. Crosby said, review this information. And I have a feeling people are getting ready. As they say here, I would love to share these slides and recording with UC pre-health students. And Emily says, agree, this would be helpful for my grad students. And this is why we have this online resource called CTR Online that CCTSTR group does provide for people to go to, and it's public and free so that people can use this in their classes, workshops here at Children's and UC Health and the VA. So if you wouldn't mind.
Yes, I'm happy to share them.
Great. Everyone else in the chat is saying thank you so much.
Thank you all.
I have a question.
Oh,
Awesome.
yes.
So yes, thank you so much. Amazing talk. I took notes feverishly, and you know that I'm thinking also from the perspective of research, because there's so much overlap between what you were talking about in the history of medicine and in racism in medicine, there's so much overlap with the racism in research.
Yes.
And in fact, it's not more or less egregious, but there's just so much overlap. And I was wondering if you could speak to some of the areas that are research specific that may not be considered when we're talking about, the clinical space.
Mhm. Mhm.
And the typical thing everybody always goes to whenever they're trying to teach about, they don't really teach racism in research, but they always go to the Tuskegee syphilis study as like the
Yes.
study. And I'd love to hear your perspective.
Yes, they always go to the Tuskegee syphilis study, which, by the way, I have found out most Black people don't even know about. Right? It's funny because everybody's always like, oh, the reason why Black people don't trust the healthcare system is because of Tuskegee. And it's like, to be honest, Black people don't trust the healthcare system because the healthcare system has never tried to develop a trusting relationship with Black people. It has nothing to do with Tuskegee. Tuskegee, most people, even as a Black woman born and raised in Alabama, I didn't hear about Tuskegee until I was in college, right? So it's even the state where it happened. That's not where people go. I mean, there is a significant history of racism in research. We know the story of Marion Sims, the father of OBGYN, who used his slaves to do his research experiments that led to how women are cared for, and to the point where, I think that they finally maybe took the big seal of his head that was in the ACOG building, the American Society of Obstetricians and Gynecologists. They used to have a huge seal with his face on it, and as the father of OBGYN, and I think they finally recognized that honoring someone who abused and tortured slave women for the sake of promoting moving the medical field forward should probably not be honored that way. But he's a simple example. And there's, of course, the multitude of eugenics, the things that were done, forced sterilizations. The American Indian population has a long history with forced sterilizations and attempts to breed out, quote unquote, genetic traits of being American Indian and or Black. There's a lot of issues with mental health issues. There were many mental health communities that were used as guinea pigs they gave them cancers and then studied them, and they were people of color that were in these hospitals that were forced to endure these trials. And it's pervasive throughout our entire history. The beauty about Tuskegee is it shows the longitudinal trauma over the development of so much in medicine and in quote unquote modern American history. That's where the shock comes from. Henrietta Lacks is always another amazing story. But the shock comes from the fact that we knew that there was a drug, penicillin, that could fix syphilis, and we actively chose not to give these Black men that drug and just watch them die and affect their families. And it was sanctioned by the United States Public Health Service, that then changed its name to the National Institutes of Health after that, right? So it's a history of our institutions doing things and not really owning it, but being able to kind of get away from it by changing their names and saying, oops, our bad. And I think that's where racism in research has to really be addressed, because when you move into modern times with research and racism, instead of it being done on Black bodies and brown bodies within the US, they just go overseas, right? And they exacerbate communities that have no power and no money, and they use and abuse in those areas. And that is still part of the side effect of a racist society of the United States, because there is the vision of Black and brown bodies not being meaningful enough to afford the same rights as white bodies do in the research space. There's a lot there. I see a hand up.
Thank you. Yes, Elizabeth's next. Go ahead.
Yeah, two things. First, thank you for this presentation. It's been, I mean, desperately sad, but profoundly inspiring to think about ways forward. A second, the fact that you have two small children in the other room who are quiet through the entire thing is also.
So excited about that.
I know I shouldn't say it out loud. They can hear us. But I have the privilege of working with the Cincinnati African American Black Interpreter Collaborative. So we are just in the starts of our research and looking at racial concordance. So I'm hoping you can talk to us a little bit more about that, because we think about clinician and patient, but then what happens when we have a white female dominated profession that then ends up being the interlocutor between these two, and what might racial concordance mean when we're talking about triads. So I was just wondering if you could talk to us a little bit more about racial concordance.
Yeah, sure. And you know, I live in Minnesota, which is like arguably the whitest state in the United States, right? And so it is, it's one of those things that is desperately everybody here is trying to figure out. And what I think is the trick is, it's not that white allies can't figure out how to do this the right way, right? And that there must be a person of color. What it really is that there has to be enough cultural responsiveness and cultural responsibility for our white counterparts. And I hate the term allies. I actually like accomplices better, right? Because allyship just kind of means we both have a common enemy, but you don't actually have to like me. We just both don't like that thing. And I want an accomplice. I want someone who's going to go down with me at the same time. Like we're both going to suffer the same effect.
Yeah.
So
we've adopted co-conspirator from Dr. Bettina Love. She
yes,
co-conspirator.
Yeah, co-conspirator. Exactly. Yeah. That's what I want, right? Like I want someone who has the same outcomes as I do in this fight. But our co-conspirators, what they can do is just kind of even just own it, right? Like own it in the moment and say, I'm your nurse today, and I realize as a white woman, there may be times where you feel uncomfortable or I do something that may be triggering, and I'm not trying to. I recognize that's the system that we're in, and I'm working on my journey of better understanding this. I will bring in others as needed. If you don't feel comfortable with me, can we figure out a way to bridge this together? Like just own it and have a conversation about it. We tend to always try and think that if bringing up race is a no-no and we should be silent. And that just makes it seem like it's a bad word, right? Just owning it and just putting it out there just completely brings barriers down to start that trusting relationship. So you can create the triad, right? It could be, I trust my white nurse more than I trust that Black interpreter, because that nurse has actually said things to me like, you know, that didn't make me feel so good. How did it make you feel when the doctor talked? Like has brought it up, who is acting in a way that fosters the relationship that's necessary in order to bring that patient through whatever journey they're going to. So I think that the white co-conspirator in the space of bringing in others or trying to be a bridge between the racial concordance in professions can have a powerful impact if it's done in a way where they just kind of own their whiteness in that space and just kinds of talk about it in that space.
Thank you. Jennifer.
Yeah, I really resonated with your comment about data fatigue because I'm a data analyst. And one of the projects I'm working on right now is with like foster care kids. And what we're seeing, you know, besides beyond just the normal disparities of color against white, is that Black girls, we are having just a huge trouble finding like group homes for them. And there aren't any. And I'm just wondering why can't we find people that'll invest in this, you know? It's just a hard situation. We build these great networks and we all try to work together, but there's just not group home type places to send these kids back to.
Yeah, it's part of the big system problems that I said, you know, earlier, when you look underneath the surface of the iceberg, there's so much there with how Black women are portrayed in America, the expectations of Black people, and whose job is it anyway to take care of them? There's a lot of this bootstrap feeling and bootstrap theory that's pervasive, like in our communities of, if you only just pulled yourself up by your bootstrap, if you only worked harder or did what you were supposed to do, then you would be fine. Like, it's not about your race, you'd be fine. And that plays out in a multitude of spaces, like not building spaces for Black people to go to when they need it because they just need to work harder and they'll be fine, right? Or they don't need any more quote unquote handouts, that they need to learn how to be more responsible and take care of their needs better, and all these other things that become the narrative that don't allow for funding to go to places that need the funding. And that's the structural racism that's built in white supremacy that has to be addressed. And that's what has to be targeted and stated, right? You look at our foster care system, you look at who are put in orphanages, who don't get adopted the most, they're inevitably Black and brown bodies, right? And so why aren't these children able to go to good homes, quote unquote good homes? Well, because there's an image of what a Black child means, and white families don't feel comfortable taking on Black children, and Black families don't get enough resources to be able to fit the need to be able to get another Black child in their house. So there's this continuous cycle that's within our that has to be addressed at its core and named. And people have to kind of have their face shoved in it before things are going to change.
Yeah. So if anybody has any ideas of how to tackle that, contact me. Yes.
Yeah.
All right.
Thank you, Jen, for that. We have one more question, if you don't mind, Dr.
Oh, yeah, sure.
Okay. This is from Alyssa. Alyssa, did you want to unmute, or would you like me to read this very quickly?
Or I can unmute.
Great.
You discussed the need for more Black clinicians. Can you speak a little bit about how to increase recruitment and retention of Black medical students and other trainees?
Yes, you have to be intentional. And that's something that we're working on at our institution. Like I said, all very white state, very few people of color, in particular, very few Black people. My institution has the most diverse population of clinicians. And I think we're 15%, right? And that's the most diverse in this area. But we see about 70% people of color as our patient population. So it's significantly different. What we're actually doing is we have created opportunities of direct community investment where we have opened up our house literally and brought in children, Black children so far through we have what's called the Talent Garden program. And we've done Black females and Black males and have spent an entire day just showing them what it means to fall in love with medicine and just invest in who they are and where they are. Because as I created the Talent Garden concept, the idea of a garden was really just an appropriate metaphor, because you can't just throw seeds outside and then hope that they grow. Some will, but you're not going to get an award-winning garden, right? There'll be a few that turn into flowers that you can pluck, but it's just not going to be it. You have to truly get in the muck and till the ground and put nutrients in there and support them and water them and protect them from the elements and do all those things in order to grow an award-winning group of talent. And so that's what we are doing, is investing in young people starting at the ages of 5 in kindergarten and trying to see the entire education continuum and break down the barriers that don't allow them to get into medical school. And while they're in medical school, break down the barriers that don't allow them to successfully complete their training. And then in residency, break down those barriers that don't allow them to continue to go forward. So it has to be a long game. It has to be intentional, and you've got to work at it nonstop, because it's not efficient to just say, I'm going to go try and find some place to recruit. You have the talent within your own communities. You just have to put the effort in where they are.